is neuropathic pain management strategies. Let's see whether we can get this moving. Okay. Well, pain in America is a big challenge. It's recognized by the Institute for Medicine as a national challenge. 116 million Americans are suffering from pain. That's more than diabetes, heart disease, cancer combined. And another number is 635 billion a year in terms of medical treatment and lost productivity. Well, what I will talk in this lecture, as well as a brief definition of neuropathic pain, its impact, its classifications, and I probably will not have time to talk about assessment and mechanisms, but I will focus on treatment options. That's hopefully give you a big picture of the treatment strategies. Well, neuropathic pain develops as a consequence of lesion or disease of the central or peripheral nervous system. And it's characterized by spontaneous pain or evoked pain. For a normal situation, as stimulus intensity increases, the responses will increase. But in the normal range, which is not painful stimuli, will usually do not cause pain. But when the stimulus intensity increases, then the pain response increases. But in situations of neuropathic pain, then there's more normally painful stimuli will cause pain, that's called allodynia, or normally very light painful stimuli can cause exaggerated pain, that's called hyperalgesia. And those are the hallmarks of neuropathic pain. So neuropathic pain affects 18% of US general population, according to recent studies. And individual suffering financial burden is significant. They cost 3 times higher than those who have the same disease without neuropathic pain. So it's our daily practice is a challenge, and it's a very important part of our practice. Well, there are many types of neuropathic pain. So there's a way to classify the different types of neuropathic pain, but it's far from ideal way of classification because in most cases the mechanisms are not very clear. So as you can see, the classification is mainly anatomical classification, focused or multifocal lesions of the peripheral nerve. That's post-surgical neuralgia, post-traumatic neuralgia, post-hepatic neuralgia, and diabetic and mononeuropathy, and so on and so forth. Well, there are more generalized neuropathic pain in the peripheral nervous system that involves diabetes, alcohol, HIV, and hypothyroidism, vitamin deficiencies, and many other genetic, toxic, and other effects. Well, there are lesions in the central nervous system. The most common ones are post-stroke pain, thalamic pain, or spinal cord injury-induced pain, or syringomyelia and multiple sclerosis. And there's a combination of peripheral and central involvements that combined complex renal pain syndrome type 1 and type 2. It's not only a peripheral issue, it's more of a central issue. According to Patrick's talk, probably the cancer pain may fall into the same category. Both the central and peripheral nervous system are remodeling themselves in response to invasion of the cancers. So apparently, the mechanisms are so diverse and complex. So therefore, it's very difficult to define the mechanism for neuropathic pain. And our previous speaker have a very good example from benchside, or from bedside to benchside, and from benchside to bedside. Actually, have a better understanding of the mechanisms, have an idea of how to target more effectively treating those kinds of pain. And I can only hope we can have this kind of insight to many other neuropathic painful conditions. Well, what is uncommon though, there are peripheral sensitization and central sensitization. So I will probably not have time to go very much details, but a lot of immune cells, mast cells, tissue damage, platelet and other cells secrete a whole array of inflammatory factors that act upon these corresponding receptors and causing the sensory nerve endings or neurons change their status, their responsiveness to nociceptive stimuli. Another important factor is the central mechanism, which involves mainly three mechanisms. That's an AMD-mediated signaling that has to do with the increased glutamate release, substance P, CRPG, and ADP, and that in turn activates AMD receptors, and that trigger cascade of signaling pathways to affect the expression of receptors, channels, and other enzymes. So that's one mechanism. So those are, there are a lot of experimental data actually to support those. A second issue is reduced inhibition. So normally you have a GABA or glycinergic interneurons that exert inhibitory effect on these T cells, that's the thalamic projecting cells. But in many neuropathic pain states, those inhibition actually can become excitation because the channel property change. So the same input will actually change the response to the opposite direction. A very important recent finding is not only neurons are important for neuropathic pain or other central nervous system processes. Those glial cells and immune cells, that's the equivalent of macrophages in the periphery. The microglia activation is a key factor in initiating and sustaining hyperalgesia and other neuropathic pain phenomena. Okay, let's talk about treatment. So what tools we have to treat those difficult questions are like one of the clinician brought about post-herpetic neuralgia. All right, so there are many different practice guidelines and the recommendations have been published to guide the physicians to practice more rationally. And there are essentially 4 categories of treatment: non-pharmacological conservative treatment, pharmacological treatment, and non-pharmacological treatment, interventional, and surgical. Some of the examples are listed here. So we work with the European colleagues to critically evaluate the available evidences and make recommendations, evidence-based interventional pain medicine according to clinical diagnosis. For instance, diabetic neuropathy or radiculopathy, and many other publications on those issues. So for pharmacological ways, there are strong evidence to support first-line choices in many situations, like diabetic neuropathy, alexithine, gabapentin, pregabalin, TCA, the tricyclic antidepressant, and post-herpetic neuralgia. You can look at this table. You find some commonalities. So opioids is always not on the first line, with one exception, that's the sexual pain syndrome. So for the most of other conditions, the TCA, anti-epileptic drugs, and a couple other local anesthetics, those are the most commonly used. And the way to choose, how do you choose those medications is mainly about the side effect profile and how familiar you are, because there is not very many comparative studies to demonstrate that one is absolutely better than the other. I mentioned the phantom limb pain actually. There's only one that's morphine as a first-line treatment. All the others, as you can say, opioid are not. You may notice that cannabinoid here, that's the marijuana. Right? So that in U.S., some states are legal, some states are not legal. In Europe, it's more common. Probably, actually, this is the European Society recommendation. Smoked cannabinoid can be a treatment for cancer pain or for HIV related pain. For non-pharmacological treatments, physical therapy, aquatherapy, home exercise, cognitive therapy, and behavioral therapy, group therapy, and you name it. And more importantly, Tai Chi and yoga. And those are not just you want to say it that way. Actually, there is a very good study published in New England Journal of Medicine demonstrating Tai Chi is very effective for instance, for fibromyalgia. But some people say fibromyalgia this strictly is not really typical for neuropathic pain, but many people do classify it as a neuropathic pain. Or acupuncture, and there are many publications and evidence to show some efficacy. And other alternatives. Well, you look at those, let's see, how effective those treatments are. And you look at literature, there's not very much. For instance, PT, how much PT can affect neuropathic pain? Not very much are published. So we actually did experiment in rats. So we train the rats to swim first, because the rats are not natural swimmers. So if we put them in a big tank, so they may want to rest them, and some people put a little weight to drag the tail down, so they have to swim, otherwise they want to drown themselves. And over a week or so, they'll every day they have 6 minutes of learning experience, and finally they get pretty good at swimming. And then it creates a nerve lesion in the sciatic nerve with constriction injury. So that will reduce the threshold to thermal or mechanical stimuli significantly. And then compare those with no swimming and those, the group with daily, every other day swimming. And you see a dramatic difference. This is without swimming, so the sensitivity is really high. So this is a control. With or without swimming, normal rest. So that the swimming itself does not change the perception of pain. However, when the rats do have nerve injury and their perception of pain changed, then the swimming make a huge difference. It brought more than like 50 or 70% to normal. And the same story applied to the thermal stimuli as well. We'll talk a little bit about interventional therapies, Botox injections, corticosteroid injection, chemical neurolysis, radiofrequency ablation, cryoneurolysis, spinal cord stimulation, peripheral nerve stimulation, deep brain stimulation, and the intrathecal pump therapy and decompression surgeries. Well, for Botox injection, I'll just give you 2 examples. So it has been studied on diabetic neuropathy, post-diabetic neuralgia, complex renal pain syndrome, occipital neuralgia, and other in animal models. But I'll give you, because of time, I'll give you 2 examples. One is actually a double-blind crossover design study demonstrating significant pain reduction measured in the visual analog scale. And so 44% patients experienced 3-point reduction at 3 months, and no similar response in the placebo group. And sleep quality also improved at 4 weeks post injection. So this is really, you can categorize it as a short-term effect. Long-term effect is not really clear. Hepatic neuralgia, that's Liz Michelle and Sean Mackey in Stanford, they collaborated and published this paper a couple of years ago. 60 patients, randomized control study, 3 groups, Botox, lidocaine, or placebo. VS score decreased at day 7 and 3 months, and Botox group was significantly lower than the other groups at 3 months. And sleep time was also improved, and they concluded that this injection may be effective. Well, corticosteroid injection, this is probably one of the most commonly performed procedures worldwide. And it can have most commonly applied to radicular pain, also hepatic neuralgia, and nerve entrapment syndrome like carpal tunnel and other entrapment syndromes. And the Morton's neuroma, that's the women with high heel and they have pain when you walk. It's really a kind of neuritis in between the digits in the foot. Well, steroid injection, I'll just give you one example to compare why people do more in transforaminal epidural injection versus this lamina. This all comes from this paper published in Clinical Rheumatology. And 31 patients, CT or MRI confirmed this herniation induced ridiculous pain. And interlaminar or transforaminal injection was randomized and controlled. And the transforaminal group did better in pain reduction, daily activity, work activities, and anxiety and depression at 6 months. So this is the rationale why transforaminal approach is more commonly used. Well, another example is herpes zoster. So this is a good study with 132 patients with acute herpes zoster. Diagnosis after skin lesion within 1 to 7 days. And standard therapy as antivirals, analgesics, or a standard therapy plus repetitive parovertebral block with the bupivacaine and methylprednisolone every 48 hours for a week. So at 1 month, the parovertebral group, 13% of patients with zoster-related pain. But in the control group, that's 45, and that's quite significant, both statistically and clinically. At 12 months, the parovertebral group has lower incidences maintained. Okay, the next modality is chemical neurolysis. You can use a phenol, use alcohol, glycerol, capsaicin. Probably can category capsaicin into that group. And there are many conditions you can use those therapies. I'll just give you one example of trigeminal neuralgia, and I'll skip the intercostal neuralgia, genitofemoral neuralgia, and the post-hepatic neuralgia. So there's a good study with trigeminal neuralgia comparing glycerol rhizotomy with this is not a randomized control study. This is a big prospective series, and it showed 92% overall success rate. Usually it's defined success with less than, greater than 40 or 50% pain reduction. I forgot this, but if it's 40, if it's 50, most people will accept it. For pharmacological intervention, 20-25% of people will say is susceptible or 2-point VS score is susceptible. But for interventional approach, because of the cost, the complication risk, and other factors, so this you have a higher bar. Usually it's set at 50%. So if you achieve more than 50% pain reduction, and it will call it a success. At 22 months, the mean time to repeat injection. So that the measurement was when the treatment failed. Fail means you have to get another injection. So that's 22 months, that's close to 2 years. That's not bad. Multiple sclerosis is a factor, it's a risk factor. So that's most the patients that need early injection, repeat injection, have higher rate of MS in that population. So glycerol rhizotomy, they concluded it is safe and efficacious. and it's particularly useful in elderly population. Radio frequency ablation. You can use thermal or pulsed or cooled. However, in the U.S., if you put a pulsed RF, usually it's not reversed, so therefore it's a problem. The reason it's not reversed is the evidence is not as strong. So I'll give you two examples of radiofrequency ablation. One is trigeminal neuralgia, and the other is post-herpetic neuralgia. So this study compared a large number of patients in three groups. One is RFA, and the other is partial sensory rhizotomy and microvascular decompression. So those are the ways to treat trigeminal neuralgia in addition to the Tegretol and other anti-epileptic drugs. So the endpoint was remission for repeat procedure or known complications within 1 year. So if you use IFA as 1, so that the relative risk factor for repeat injection is for partial sensory rhizotomy is only 1/5. But for microvascular decompression, that's 1/8. So that is the risk for repeat procedures are much less for the two surgical approaches. However, the relative risk for complications, like the partial sensory rhizotomy, is 5 times more than radiofrequency ablation, and the microvascular decompression is 4.4 times more complications or animation. So this is very significant. You have to weigh the cost and cons and look at each individual patient to make your clinical decision whether the patient have high risk of those are procedures, are not trivial procedures. High risk of complications. So if those complications is a main concern, probably you would go for radiofrequency ablation. If you want maybe a longer term period, the patient is relatively young and healthy, otherwise maybe micro decompression or surgery may be appropriate. So there's no black and white, but you have to know your patient and make a rational decision and justify your decision. Okay, pulse RF, I would kind of skip this one because that's really the evidence is not that strong. Okay, prior neurolysis, actually this is a kind of underutilized technology. It was developed 50 years ago. And just before intercostal neuralgia and other type of neuropathic pain. And it used a very short freeze-thaw cycle causing axonal degeneration. So the beauty of this technique is it preserves the epineurium and perineurium. So that's allowing regeneration. So that will not causing a neuroma in the long run, in the future. So we reported, so this is probably the largest patient sample size, 51 patients, chronic neuralgia of ilioinguinal, 20 cases, intercostal, 16 cases, genitofemoral, 8 cases, and lateral femoral cutaneous nerve, 3, and a few other neuralgia peripheral nerve. And 60% pain reduction at 1 to 3 months follow-up. So we really need a long-term follow-up. But usually what happens is the patient when they have a good response, they do not come back so many times, no news is good news. When they call you about a year, the pain is coming back, and you repeat the same procedure, and usually it works just as well. So from this study, it is quite clear that if you treat the right patient, it can achieve quite significant pain reduction for extended period of time without complications. Spinal cord stimulation, evidence for stimulation is very strong for field back syndrome. So more people, you compare people with spinal cord stimulation for field back or repeat back surgeries, and spinal cord stimulation wins every single time. And also there's increasing evidence for post-hepatic neuralgia, peripheral neuropathy, and other neuropathic pain conditions. But in our recent publication, we look at about over 700 cases. So those are the cases, the indications for spinal cord stimulation. It's mainly CRPS type 1, and type 2 is less frequent. Field back surgery syndrome, peripheral vascular disease, and visceral pain about 5%, and other neuropathy 10%. And so those are the trial implant ratio. You try, let's see, 100 patients, about 85% of the time, patients that is really effective, I really like it, I want an implant. So that's not a bad ratio. Peripheral nerve stimulation is most commonly used for occipital neuralgia, for intractable migraines or cluster headaches, and it can also use other branches of the facial, like branches of trigeminal nerves, and the complication rate can be an issue because there's very little tissue underneath the skin. Therefore, over time, the electrode can erode the skin, and it can be a problem. Even for occipital nerve neuralgia, the average revision time is like 3.7 times over a 2-year period. So that's to me, that's too high. You have to bring the patient 3-4 times, 2-year period to do the revision. That's not acceptable. But in this selected patient, it really provides good pain relief. On the watch out, you see peripheral nerve field stimulation for grooming pain, abdominal pain, and other problems. Again, in U.S., the reimbursement can be an issue. Sometimes if you do not define which nerve you are stimulating, the insurance companies does not like that. So the field stimulation as stimulation nowhere. And a new direction that was recently taken to total root ganglion stimulation. There's very little data published on this. Just want to watch out. Okay, deep brain stimulation. We do not do this. We have a multidisciplinary group. We have in our department we have a neurosurgeon who is doing deep brain stimulation and cortical stimulation. for movement disorder, Parkinson's, and the pain. And particularly for deafferentation pain, like facial deafferentation pain, it can be quite effective. Well, intrathecal therapy, when you use a pain pump, so you try everything else, nothing really works, and the patient really needs pain relief, and you give a lot of opioid, keep escalating the dose to a point, a lot of side effects, or it's just not effective. Then in that case, you might want to take another approach to use intrathecal therapy. By doing that, you'll reduce the requirement by at least 100 times less. And you can, sometimes it can be a good solution for many patients. But you have to be really careful because particularly for the young people, under 55, the same thing will happen again for intrathecal and for oral. Because escalating to a point, you can have granuloma. Because when the dose is really high, you increase the rate of granuloma, and that's not fun. It can be very tricky to manage. Well, the first line treatment for a choice for intrathecal therapy, morphine is one, and dilated or zyconitide, so that's the pre. And it first started in cancer pain patients actually, and later on it's also tested on non-cancer pain and can be quite effective for very selective patients. I mean that's very selective. The success rate is around 30%. You can test 3 patients, 1 person. If you really got the patient, it can be a charm, but just success rate has not been that high. Well, there are situations that you can use minimally invasive surgical approach, like for minimally invasive lumbar decompression. I presented in conference in China with some of the friends in the audience. Well, that is what I talk about. So I will briefly talk about the definition, classification, and central and peripheral sensitization, and treatment options, and pharmacological, non-pharmacological, and interventional. Interventional, I'll talk about Botox injection, steroid injection, cryoneurolysis, chemical neurolysis, spinal cord stimulation, peripheral nerve stimulation, deep brain stimulation, and intrathecal therapies. A big picture, and there are many good references. You can, if you are really interested, if you want to apply in your practice, I would recommend you to do some of those. The first hand reading. It's just a very short period and I cover a lot of ground. I cannot go into too much details. Thank you very much.